Good morning, everyone. I'm Diane Perez, and on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar entitled Introduction to Harm Reduction and Assessment. This webinar is being made available through a collaboration of the Florida Department of Children and Families Office of Substance Abuse and Mental Health and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to the presenter and me, the host, by using the Q&A panel. The button to open the panel is usually located on the upper right side of your monitor. Please use the Q&A panel to send any questions you may have as you think of them. The presenter will address questions as time permits. Our audio is broadcast through the internet to your computer. If you experience more computer audio, there are a few options to try on screen right now, and these options will be posted in the chat panel too. If you continue to experience poor audio through your computer, try rejoining the webinar and call in using the telephone I will call in option. You must be connected to the audio of this presentation and view it on screen as well to receive a certificate of attendance. The recording and materials used in today's presentation will be available on the FADA website within 10 business days. To access the recording, go to www.fada.org. Also, a PDF version of this PowerPoint presentation will be emailed to participants with that same time frame. FADA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on the FADA website. You will first need to register or sign in to your account to complete the evaluation. Information you provide FADA as part of registering remains confidential. Statements of credit will be posted within 5 business days after the evaluation closes in individual professional development journals for persons completing the evaluation and attending the full webinar. Completing the evaluation is necessary to receive CE credits or to access your statement of credit. Do note that the evaluation will close at midnight on Wednesday, February 13th. 1 to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are licensed healthcare practitioner, be sure to include your Florida license numbers for reporting to CE broker when you register with our site for the first time. If you are certified with the Florida Certification Board or licensed outside the state of Florida, you don't need to provide your certification number when you register with our site. Note, please, that WebEx monitors arrival and departure of attendees and provides a report upon completion of the event. We are not permitted to provide contact hours or a certificate of attendance if you do not attend the entire webinar. We are not permitted to provide partial credit. Let me introduce today our presenter, Susie Kowalsky. Susie Kowalsky has been serving vulnerable communities for more than a decade through direct clinical services, as well as by delivering training and consultation to service providers. As a trauma therapist, Susie works with diverse populations to address issues related to complex trauma, substance use, mental illness, chronic health conditions, sexual orientation and gender identity, couple and family relationships, and systematic oppression. Susie also provides training and consultation to master-level students, clinicians, programs, and organizations on a national level. In her roles as a therapist, clinical supervisor, and consultant, Susie emphasizes a relational approach in which healthy connections facilitates the development of insight, practice of new skills, and curiosity for continued growth. And now, I'd like to welcome our presenter, Susie Kowalsky. I will turn the presentation over to you.
Thank you, Diane, for the warm introduction, as well as for all of your work to bring this webinar together. And I also want to thank FATA for inviting me back to present on this topic. I'm really thrilled to be here with all of you. And last but not least, I certainly want to thank all of the participants who took time out of your busy day to participate in this webinar. I know that you all have a lot on your plate, so I'm glad that you're setting aside this time for us to be together this morning. So here's my contact information. My name is Susie Kowalsky. I am coming to you today. I work and live in Chicago, so it is a balmy 29 degrees here, which is actually much, much warmer than it's been in the past couple of weeks. So all of you can be glad that you are almost certainly in warmer weather than we are here. But here's my contact information, and feel free to get in touch with me. It's always nice to hear from people who've participated in trainings. And a little bit about my background as it pertains to harm reduction. So throughout my career, I've worked in domestic violence shelters. I've worked with people who are mandated to treatment, either for domestic violence or substance-related issues. I spent several years doing homeless outreach to people experiencing homelessness along with serious mental illness. I worked in a formal substance use treatment program that operated from a philosophy of care that included harm reduction. So harm reduction has been really integral to a lot of the work I've done. So I'm really excited to be talking with you about it this morning. And you can see here my website is practiceforprogress.com, and that's kind of a nod to the idea from harm reduction that we're really focusing on progress, not perfection. So harm reduction is definitely like a big aspect of my professional identity and my approach to the work. So I'm excited to talk with you about it this morning. Here's kind of our roadmap for the morning. We'll start out by really talking about like what is harm reduction and what are we talking about when we use that word and that phrase, and talk about some of the key principles involved in harm reduction. We will take a break after that. So we'll take about a 10-minute break about halfway through our time this morning. After the break, we'll come back and talk about this concept of drug set and setting, which is really kind of a really nice assessment tool to understand someone's relationship with drug use. And we'll talk about this third objective somewhat throughout so now that we kind of have some understanding about harm reduction, how can we integrate that into the services that we're providing? Throughout the training, there'll be some times where I'll ask for your participation, and I'll try and remind you when we get there, but if you can type your responses into the Q&A rather than the chat, I'll try and keep my eye there so that we can kind of have a conversation together. And then if you have questions or comments that come up, please feel free to go ahead and send them in. And then some of them I might answer kind of throughout as I see them. Some of them we'll talk about at the break. And sometimes I might ask to kind of put that on hold if it's something that we're going to talk about shortly. So that's kind of where we're going today. So I want to start out by talking about an activity that can be both very pleasurable as well as practical. Some people think that it's too risky, so they avoid it altogether. And every year, many, many people are harmed and even killed while doing it. When people do it, we encourage them to do it safely. So I'm talking, of course, about driving a car. So if you could all type into the Q&A, what are some of the policies and practices that we put into place in order to stay as safe as possible when we're driving a car? What are some of the things that we do around this risky activity? Yeah, so we wear a seatbelt, absolutely. We know that it is very possible and sometimes even probable that we might get into an accident. We have speed limits that we put into place. We ask that people don't text and drive, that they really focus on what they're doing. Right, we talk a lot about drinking and driving, and not only do we have laws around it, but it's something that we have like a public conversation about. We try to be defensive and alert. We want to pay attention to what we're doing, respect the signs and laws. Absolutely. So you all are naming, there are a lot of things that we do in order to take this pretty dangerous activity that's pretty risky and make it as safe as possible. One of the things we recognize through all of these different considerations that we put into place for driving is that the choices we make in a car don't only affect us. There are personal risks to us driving, but there are also community risks to driving. So we recognize that we're going to have an impact on one another, and we have some things in place to try and regulate that. One of the other things, though, is that there are some rules that try and make driving safer, and some of them are official laws. Other things are pieces of like kind of common sense or other safety practices that we pick up along the way. But there are many things that are left unregulated. So, for example, we have suggestions of when to get your oil changed, but it's not something that if you haven't had your oil changed, there's no one who is out there checking on that and preventing you from getting in your vehicle. Something that may not come up as much in Florida, but certainly comes up here in Chicago, is how much can or should you really be driving in inclement weather? We had a ton of snow and ice in the last several weeks, and there are certainly vehicles that are not particularly well equipped for that kind of weather, and people still need to get around. So things like that are like how loudly you can listen to the radio in your car. That could certainly affect some of the things that you all named, like being focused, paying attention, limiting your distractions. And while we might encourage people to listen to the radio at a reasonable volume, there's not something that absolutely prevents someone from being able to drive if they're listening to the radio very loudly. So this is a pretty dangerous activity. You may be aware that until very recently, car accidents were the leading cause of accidental death, and then several years ago, they were surpassed by drug overdose in terms of cause of death. So there's a lot of harm that comes from people driving cars, but yet we continue to do it. And we make both explicit and implicit agreements with each other about how we can make this activity as safe as possible. So one definition of harm reduction that comes from Marlott is that harm reduction is a set of pragmatic and compassionate approaches that aim to reduce harm and improve the quality of life for people engaging in high-risk behaviors, based in a humanitarian stance that accepts that people will engage in risky behaviors. So if we think of this as a definition of harm reduction, I think we can see where this certainly applies to driving. There are a lot of things that we put into place in order to reduce harm and improve the quality of life for people who drive, based on this acceptance that driving is really risky, but people are going to do it. So in thinking along those lines and thinking about this definition, what are some other areas of our lives where we are already practicing harm reduction? So if you can go ahead and type in your responses to the Q&A about other parts of our lives where we practice harm reduction. Yes, Robert mentions healthy eating. So we have a lot of guidelines about some of the things that are healthier for our bodies. We can consume all sorts of stuff that may not be very good for us, so we have guidelines around it. And we also accept that people are still going to eat things that may not be particularly good for them. Smoking and drinking is another place where we already practice that. So sexuality. There are a lot of risks that come from sexual activity, and we provide people with information and resources to reduce the risks of their sexual practices. Taking medications and exercising. So I'm going to break those apart into kind of two different ones. So taking medication, and I would say even healthcare in general, right? Not a ton of people follow all of the guidelines and suggestions that a doctor might make about what medication they should take, what type of physical activity they should engage in, and what kind of diet they should maintain. At the same time, if I go to the doctor and they say, are you exercising for 20 to 30 minutes, 2 to 3 times a week, and I say no, they're still going to treat me and talk with me about things that I can do to take care of myself. In terms of exercise in safe ways, I think that that can come in a few different forms. So in general, practicing and participating in sports is pretty dangerous. So when we think about professional sports as well as, people's individual participation in sporting events as a player, there's a lot of things that could be pretty risky. So even within sports, we have rules about what kinds of things you can and can't do to try and keep that a safe activity for people. In bicycling, Michael Brown mentioned that we have to wear helmets. It's something that we do. It's pretty risky to bike. I don't know about in Florida, but especially in the city of Chicago, there are bikers all over the place, and biking on the sidewalk is a major no-no. They have to bike in the street, and it's definitely a lot safer if you are wearing a helmet. So we can see a lot of areas of our lives where we can and do agree on ways to practice harm reduction in order to take these somewhat risky behaviors and try and make them a little bit safer for both individuals and communities. With a lot of these things, there are activities that we don't necessarily have to participate in, but we do because they bring us some type of enjoyment or alleviate some kind of need. So again, I think one of the parts of this definition of harm reduction that we want to focus on is this last piece about accepting that people will engage in risky behaviors. So we're not telling people that you should just never do this. Instead, we're really talking with them about how do we make it as safe as possible to do this risky activity. So I think that begs the question then, why is it different with drug use? If we have all these other parts of our lives where we can pretty readily agree people are going to do these things and they're pretty risky, but we're going to accept that they're going to do them, and we're just going to try and keep people as safe as we can, also acknowledging that there's going to be some harm that comes from that activity. What is it about drug use that is so different, that feels like there's just a different quality to our approach. So again, if you have thoughts, feel free to enter those into the Q&A. Like why is it so different with drug use? So one of the things that I think we need to keep in mind when we're talking about drug use is that we are all people with lived experience, and we many times, especially in the world of substance use treatment, it's our personal experiences that brought us to this type of work. And that has a lot of value, and it often can give us insights or information that we may not otherwise have access to. And we have to recognize that that is our personal experience. So one of the things for us to consider is that we always bring our own lens to our work, and that our history and our experiences are going to really be influential in our attitudes, beliefs, and approach to the work. So one of the things we need to be really conscious of is what's my bias. So I want to mention, I see in the chat that you're not able to see everyone's answers. I'm not sure, some of you, it looks like maybe sending that to me privately. So I think where there's that little 2, if you send it to all participants, other people may be able to see it. But I appreciate you putting in your responses. So with drug use, there's potential for criminal charges. We may not know how severe it is, and it affects a lot of different people. And I would say that if we kind of back up and think about some of those other activities that we've already talked about, that those things apply there as well. Someone who is driving way over the speed limit, there's potential for criminal charges, and that certainly can affect other people and be pretty severe. But there's something specific and really unique to drug use that brings about a different set of response. So there's absolutely a different set of social and moral judgment around drug use. And absolutely, there's the potential for drug use to cause death. And we also know that there are a lot of other risky behaviors that have the potential to result in death. And we tend to have kind of a different approach to them. So one of the things, again, that I really encourage people to think about is just like, what is the bias that I bring to this work? And also, where do some of those biases and beliefs come from? So an interesting study that was done in the UK by David Nutt is that he looked at what is the cost to society of MDMA. So this is at a time where people were really concerned about the effects of MDMA, which is like Molly or ecstasy, and the cost to society in terms of injury, death, medical costs, hospital stays. And it was something at this time that was being really talked about, and a lot of attention was given to the idea that this is a really risky behavior with all these significant impacts. And what he did was actually he compared that to the same costs to society for horseback riding. And what he found is that there's a lot more injury, death, and collective costs to society from horseback riding than there was from MDMA. So again, the way that things are framed and talked about can really influence the way that we think about them and the way that they're framed in the media. So in thinking about this question of what does a drug user look like, very often this is not the image that comes to mind. We think about people who have experienced the greatest harms from their drug use, and there's a lot of media attention on people who have the most dramatic and harmful consequences of drug use, and we don't talk about the many, many people who are able to and do use drugs in very well-managed ways that may actually contribute to some of their success. So back in the 90s, there was a study that asked people to picture a drug user and describe that person. And 95% of the respondents described an African-American person. So we also know that the vast majority of people who use drugs in our country are white, and that African-Americans make about 15% of the people who use drugs, which is about equal to their proportion in the general population. So even though drug use occurs pretty evenly across demographics, our picture of a drug user is very heavily skewed along racial lines. So again, something for us to consider of why is this so different around drug use, and acknowledging some of the racial and historical components to even the ways that our drug laws are created. When we picture a drug user, we don't readily think of the people who've used drugs, so things like executives, scientists, writers, musicians, politicians, and even presidents. One of the other questions that I think this begs is, what is a drug? And so we are talking in this case about any substance that in small amounts produces significant changes in the body, mind, or both. So that is a pretty broad definition that includes prescription medications, over-the-counter medications. It would also include caffeine, sugar, different types of food. So there are a lot of things that we put into our body that result in changes to mind, body, or both. So one of the questions, again, that I think this begs is like, does it matter how you use it? And how do you determine if the effects are strong enough? So kind of backing up and taking some time to talk about like harm reduction more specifically, we can see a couple different definitions. So in addition to the Marlott definition I already showed you, here we see from the International Harm Reduction Association that we're talking about policies and programs which attempt primarily to reduce the adverse health, social, and economic consequences of mood-altering substances, both to individuals, their families, and communities, without necessarily requiring a decrease in drug use. The Harm Reduction Coalition gives us principles that include a practical set of strategies and ideas aimed at reducing negative consequences associated with drug use. They also add that it is a movement for social justice built on a belief in and respect for the rights of people who use drugs. So again, I think that the second definition here really adds in that social justice movement that recognizes that people's rights don't automatically go away because they participate in drug use. So that's something that we'll come back to. I think that harm reduction sometimes for people who have not had a lot of experience with it can sound sort of scary or foreign or like this really kind of out there idea. And so we're going to spend some time talking through the ways that philosophies of care that we're already very familiar with and that I'm guessing many of you would say that you are already using and would consider part of a best practice. We're going to talk about the ways that harm reduction really has a lot of overlap with person-centered care, strengths-based care, trauma-informed care, and solution-focused approaches. So harm reduction is very person-centered. One of the very common phrases that we talk about in this field is that we want to meet people where they're at. And that's one of the things that harm reduction really champions. Well, I think a good question is, how do we meet people where they're truly at rather than where we want them to be? I think by actively collaborating with people who are receiving services, we send the message that we really value their ideas and opinions and experiences. We know that for most people, they are going to be more of the expert in their own life. And also at the end of the day, it is their life. So we don't get to make decisions for people about what's important to them, what might work best for them, and what their experience has told them about themselves. Those are things that we really need to hear and give voice to from the people who are participating in our services. So I think a big way that harm reduction is person-centered is that it's really giving people voice in the program. We have to listen to people and kind of give up that expert role and be able to actively seek out feedback from the people receiving services and incorporate that into our service delivery. Harm reduction is very strengths-based. So we recognize that many people's drug use starts as an adaptive response. People don't set out they don't set out to start using drugs in order to ruin their lives. People are generally doing something to try and help them cope with some type of situation. And we'll talk a little bit later about some of the reasons that people might engage in drug use. But I think it's more than just recognizing that our clients have strengths, but about really believing them and prioritizing their view of the situation and being able to leverage their strengths in order to move toward whatever their goals are. So backing up, a big part of person-centered care is that we don't get to decide for people what their goals are. So it's someone's goal as they define it for themselves, and I think that includes this idea and concept of recovery. We don't get to determine for someone else what recovery is. It's something that we really need to partner with people to find out what would that mean for them. And I think that's where harm reduction also comes into this idea of celebrating any positive change. Change is not an easy process. I think for any of us who've made efforts to make big or small changes in our lives, we recognize that it's a process, not something that happens in one fell swoop overnight. I think one of the things that we know from motivational interviewing is that people get really discouraged when they're trying to kind of measure up to this idea of a perfect 10, and they might feel like, on a scale of 1 to 10, maybe I'm at a 2 or 3. And so I think when we give people airtime to talk about the things that are going well in their lives, the things that they're good at, the things that might help them move toward progress and the small incremental change that we recognize, it builds people's motivation for continued growth. I think in harm reduction, we also redefine success, and I think that's an important part of us being able to mean ourselves in this work, is that we're not necessarily waiting and looking for someone to make all of the possible changes that they could make in their lives before we really celebrate with them and acknowledge also the very hard work that we do. So we're able, kind of the phrase of the Chicago Recovery Alliance is any positive change as a person defines it for him or herself. Harm reduction is trauma-informed. So trauma is one of my great professional passions, and we absolutely know that there is a huge influence and cyclical relationship between substance use and other risky behaviors and traumatic events. So for many people, it can be really hard to tease apart kind of like which came first, the trauma or the substance use. But rather than focusing on which came first, we also know that these are things that tend to reinforce each other. We also recognize that substance use has been a central part of a lot of people's trauma story. It was either involved in the traumatic event itself. It might have been part of how they coped with it. It could have been both. But there's a really close relationship between people's experiences of trauma and risky behaviors. We also recognize that the way that trauma affects people's brains may make them more inclined to participate in risky behaviors. Thinking through a trauma lens, though, we also recognize that directing and shaming and blaming and threatening people into changing their behavior can be effective. We can shame someone into making a change, but for one, that's not going to typically result in lasting change. But also, those types of dynamics really mirror a lot of dynamics of traumatic experiences where people aren't given a sense of power empowerment in their lives, and it creates this sense of hopelessness where I'm just sort of forced and bullied into doing this thing that doesn't really feel authentic. So we want to be really careful not to mirror those types of dynamics. We also honor that people have the right to make their own decisions, and we recognize from our experiences in trauma and our knowledge of trauma that it's really important to support people at moving at their own pace. And I think often that comes from a really good place where it's really hard to stay engaged and work with someone who's participating in risky activities, and it's hard for us to see people do things that we may never choose for ourselves. And we also recognize that we're not being trauma-informed if we force people to make the decisions that we think they should make at the pace that we think they should be moving at. Harm reduction is also very solutions-focused. So again, this requires that we give up the expert role and come to a place of not knowing and approach people from a place of curiosity and recognizing their strengths. One of the other things that I think is an important part of solution-focused work is that we don't have to convince people that they have a problem in order to help them find solutions. People don't want to come to our offices to talk about all of their deficits and all of the ways that they're making decisions and engaging in behaviors that are causing all sorts of problems. Very often, particularly by the time someone is coming to us around substance use or other risky behaviors, they have plenty of outlets in their life where someone is more than happy to tell them about all the terrible decisions they've made and all of the harsh consequences of that. What people don't often have is a place where they can talk about what is it that you think you can do and what would be helpful in this situation. So really shifting our focus from the problem to a solution, I think, gives us a lot more room to work with people. This also helps people feel very understood and supported. So the other part, I think, of solution-focused approach that is important is that we are giving people transparent information to help them make informed decisions. So we are giving up that expert role, but we're also staying engaged with people so that they have information that they would need in order to think through what might work best for them. Harm reduction is really pragmatic. So we recognize that substance use is a very, very long-standing human phenomenon, and we're not ever going to have a substance-free society. It's been a significant part of societies going back to like the Neolithic age. It's been a part of personal, cultural, and religious human experiences for the past several millennia. So harm reduction is acknowledging we're not going to try and eliminate all substances forever because that's not very practical. Harm reduction also recognizes that there are actually benefits on both a personal and societal level to substance use and other risky behaviors in the same way that we think about things like driving a car. That's a very risky activity, but it also has some benefits. There are reasons that people do it. Harm reduction acknowledges substance use to exist on a spectrum. So the idea that once someone engages in any form of use, they'll engage in substance use in a chaotic way is not true. The vast majority of people who try any substance, legal and illegal, don't develop a substance use disorder and don't use necessarily in problematic ways. And we'll talk about kind of the spectrum of substance use that can exist. Harm reduction also recognizes drug addiction as being a biopsychosocial phenomenon, and that's really a lot of what we're going to talk about in the second half this morning is those different components. But it's not just about the person, it's not just about the substance, it's about these three different overlapping components. Harm reduction is also pragmatic about the idea of recovery and safety. So we know that there is no one model of substance use treatment that works for everyone. And when something works for many, but not some people, we tend to assume that there's something wrong with those some people for whom it doesn't work. And I think harm reduction kind of takes a step back and says, maybe it's not that there's something wrong with this person, but that this is not the right match for this person's needs. And maybe we need to find a different approach to be able to address what this person needs at this time. Harm reduction also recognizes that limiting treatment options to one size, which typically in our case means abstinence only, limits the number of people who we're willing and able to serve. And so when we're not working with people until they're at a place where they're saying, yes, I want to and I'm ready to pursue an abstinence-only approach to my relationship with drugs, we miss a lot of people who could benefit from information and resources that would reduce harm, including death. So in thinking about our current overdose crisis, I think one of the risks we have if we're not practicing harm reduction is that we're not accessing many of the people who are at the greatest risk for overdose and death. When I worked in substance use treatment, one of the things that we very, very frequently did was we widely distributed naloxone and talked with every single person who walked through our doors about overdose education information. And so if we're not opening our doors to people who are not saying, I want to pursue abstinence, we're not giving a lot of people resources that would help save lives and reduce the impact of overdose both individually as well as on a community level. And then I think last but not least, harm reduction also recognizes that we can't create solutions and goals for individuals and communities without incorporating their input and feedback. So we can't come into a community and say, here's what you all need in order to address this issue. We really need to be hearing from that community about what their self-identified needs are. Harm reduction is grounded in human rights. So we honor and recognize that every single human being has inherent dignity and worth. We're not, in terms of offering low threshold access to services, we're not going to deny people services that we recognize as part of their human rights, so things like health care and housing, based on the progress or status of their goals. And that includes people who are engaged in risky activities. So we know that taking away access to health care and housing is not going to help someone address their substance use or other risky behaviors. And it's also coming from this very human rights oriented place of recognizing that like people have a right to those things and we can't take that away based on their engagement in risky behaviors. There's a question about the personal and societal benefit to substance use and risky behavior. I'm gonna we'll speak to that in a little bit. So thank you for your question, but I'm gonna put that on hold for just a minute. In terms of human rights, we see a lot of areas that we restrict people's access to resources based on their engagement in substance use. So for example, drug testing people in order to receive food stamps, the determining factor for whether someone is eligible for food stamps is whether they are of low income, because we recognize that people need to be able to eat. And so taking away a drug user's access to something as basic as food is not really honoring that person's human rights and worth. We often deny people housing for using drugs. We limit their access to health care and treatment. And so I think we can see a lot of areas where we sort of dehumanize people who are engaged in drug use, and we take away some of their right to different services and opportunity that we wouldn't do for other individuals. So last but not least, harm reduction is focused on reducing harms. So we're not talking about convincing people not to engage in behaviors. So thinking back to the car, our approach to car accidents and some of the harms of driving cars, we're not saying no one should drive anymore. This is too risky. We just have to get all of the cars off the road and convince people that they should never drive anymore. Instead, what we're doing is really identifying what are the risks and harms of this activity and how can we reduce them. So we're looking really at the consequences of a behavior rather than the behavior itself, because that is where the harm lies, not just in what someone's doing. So I apologize, Diane. My computer has once again decided to shut down on its own, so I'm going to keep going, but I will need your assistance to move things along. So in terms of what's under the harm reduction umbrella, here's where I like to really step back and talk about the broader philosophy of harm reduction versus specific risk reduction strategies. So things like a needle exchange or safer use strategies, condom distribution, even birth control are examples of specific risk reduction strategies. They're things that we can work with people to arm them with information and tools and resources to reduce the risk of a behavior. That's a little bit different from this overarching philosophy of care that includes these different components of like a social justice and humanitarian stance. So I think it's worth pointing out that not all risk reduction strategies will necessarily fall within a harm reduction philosophy of care. So for example, one of the things that I know we see here in Chicago is that there are some housing programs that will say, we're a harm reduction housing program. Even if you're still using drugs, you can live here because we recognize that having a roof over your head reduces your overall risk. So you can still live in this housing program and will reduce your risks associated with homelessness as long as you're trying to stop using. So if you're saying, you know, my substance use I think is at a fine place and I don't see problems with it and it's working well for me and there aren't necessarily negative consequences associated with my use, that's not okay. You can't live there if you don't want to make the change. So that is an example where we're not working within harm reduction framework because we're prescribing goals for people, but it is a risk reduction strategy because we're giving someone access to a resource that reduces the risk. So I just like to point that out. Diane, if you can move to the next slide, please. So I think this idea of gradualism is what I was just naming. As a lot of times we talk about harm reduction as meaning that as long as someone is gradually moving in the direction of abstinence, we'll work with them. Substance use management is a practice that kind of moves beyond that idea and talks with someone about their self-identified goals in order to manage their substance use in such a way that reduces their risk of harm, but may not necessarily include abstinence. So I think the idea of substance use management really challenges this notion that people who use drugs don't have the ability to make good decisions. When we give people support and education and adequate resources and a sense of belonging, we actually see that many people who are engaged in drug use can and do make thoughtful, reasonable, and safer choices about their drug use. The vast majority of people who use drugs are engaged, whether they know it or not, in some type of substance use management plan. So this could include things like I may only drink alcohol after work and within a certain limit and in a certain context. It's important to eat a good meal, not drink on an empty stomach, and to do things like drink water, not drive. So those are all examples of components of a substance use management plan. And we'll spend the second half talking about drug set and setting and kind of how that fits in with substance use management. We can move to the next slide. I want to talk about some myths and misconceptions about harm reduction before we move into our break. So the next slide talks about this myth that harm reduction enables risky behavior. And it's kind of this idea that if we don't tell people to stop, it feels like we're telling them that it's okay. So harm reduction addresses risky behaviors without judgment, which is definitely not the same as allowing it or saying it's okay. It's more a recognition that this is going to happen whether we approve or condone it, and so we're taking a neutral approach to it because we know that feeling judged or controlled doesn't result in people being able to make the changes we think they should make. What it does is drive those behaviors underground, and people are hiding what they're doing. People who are engaged in risky behaviors are doing so without the approval of their family, service providers, and society. So people who are engaged in risky behaviors, despite experiencing repeated negative consequences, they're not continuing to do those risky behaviors because they think they've been given permission. So I think the underlying factors of why people are doing the things they're doing are much more complex and individualized, and that's where we use this idea of drug set and setting to have a much more nuanced understanding of someone's continued substance use. In terms of thinking that we're encouraging risky behaviors with harm reduction, I think that really underestimates the complexity of the factors that go into shaping someone's decision to engage or not engage in risky behaviors. Some people think that helping people to reduce the harm they experience in their lives sends messages to others who don't engage in risk behaviors that it's safe to start or return to those behaviors. And what we've actually seen in research is that it's the opposite. So in needle exchange programs, there's never been evidence to show the increase of rates of injection substance use within a community where we're providing access to clean syringes. In fact, it's quite the opposite. So we see that having a needle exchange program actually decreases the rates of use because people who are actively injecting are more likely in that case to connect with service providers and engage with substance use counselors around reducing or stopping their use when they're allowed to do that and discuss their use openly and in a non-judgmental environment. So harm reduction services really increase the probability that people who engage in risky behaviors will be able to access medical care, engage in social services, and also increases the likelihood that they might at some point ultimately stop those risky behaviors. In terms of the notion that harm reduction is antithetical or opposed to abstinence, I think this is something where, as a harm reductionist, I have to say I don't think we always do a great job of recognizing abstinence as falling under the harm reduction umbrella. I think one of the things that I think I saw in my experience working in formal substance use treatment with people who many times their goal was abstinence, is that a lot of harm reductionists struggle to apply principles of harm reduction to abstinence, but there's not any kind of theoretical barrier there, and I think what that looks like in practice is talking with people about the risks and harms of abstinence, so making sure they have information about withdrawal and overdose, and then also talking with them about what are some of the potential risks to their abstinence. So that might be people in their social settings and other triggers that might lead to relapse. Harm reduction doesn't take a stance on the legality of substances. So it applies equally to both legal and illegal risk behaviors. So things like the use of tobacco and alcohol in our country are legal, and there are many other substances and behaviors that are illegal. And so harm reduction is pretty neutral on whether substances or other risky behaviors, such as transactional sex, should or should not be legal. So we're not saying that these things should be legal. We're just saying that this philosophy is applied equally regardless. There are absolutely some advocates of harm reduction who want to see changes in the way that governments attempt to control the distribution and use of illegal substances, and there are many who do not. So those are really personal views that are not a part of harm reduction practice or philosophy. This notion that harm reduction is this idea that like anything goes and people can kind of get away with or do whatever they want. I think that kind of speaks to the first couple bullets here, that we're not giving people permission to do things, and people aren't engaging in behaviors because they think we've given them permission. They're engaging in behaviors for their own set of reasons. But there are absolutely hard lines in the sand with harm reduction, and that line is typically around safety. So if someone is an immediate safety threat to themselves or others, that's where, like in any other case, harm reduction would intervene, and we would do what we need to do to make sure that everyone stays safe. Harm reduction isn't a threat to public safety, and again, research consistently shows the opposite. We see that harm reduction programs actually have a positive impact on public health by decreasing rates of infection of bloodborne viruses, decreasing rates of substance use and other risky behaviors, increasing people's engagement in medical care, social services, and that includes substance use treatment. Harm reduction definitely helps decrease rates of death due to overdose, and then also increases the rate of people like properly disposing of biohazards, so things like syringes or other contaminated instruments, which if they were improperly disposed of would lead to greater public health harms. I like to talk about the idea of safety versus comfort. I think sometimes we conflate the two and think about, if I'm feeling uncomfortable, there is a safety risk. And when we're working with people who are engaging in risky behaviors, it's going to be uncomfortable because this is a person who we genuinely care about, and we want them to be as safe as possible, and we're witnessing them engaging in behaviors that we may not ever choose for ourselves. That doesn't necessarily mean that there is an immediate safety risk. So I think having adequate support to talk about how do we manage our own anxieties and fears and working with people is an important piece of harm reduction as well, getting the support that we need. So the executive director of my former agency would talk about this idea that, kind of speaking to that idea of like harm reduction is easier, it's anything goes. He'd say harm reduction is the harder path. It would be easier to turn our backs on people or refuse some services. And what's really difficult is staying connected to a person who's continuing to suffer consequences from harmful behaviors and supporting them along the way. So this is, if you can go to the next slide, Diane, it's time for our break. And Diane, if you could read any questions that have come in, I can address a couple of questions before we take our break.
So, Susie, would you comment further on how there is personal and societal benefit to substance use and risky behavior, please?
Sure. So we are going to talk about that a good amount in a little bit. But for example, I drink coffee every morning, and it causes me to be able to get up in the morning and take care of a lot of the things that I need to take care of. Again, if we're broadening our definition of substance use, we use it a lot in medical practices to treat disease, to help people manage different illness. We see that with a lot of trauma, substance use can be a way that people do manage trauma. And then it's also a big part of a lot of religious practices. So it can contribute to a sense of belonging and community. And I think one of the things we'll talk about is some of the ways that sometimes we think of substance use as substance abuse, and we kind of leave out the people who are engaging in substance use in ways that aren't necessarily causing problems, but maybe bringing about benefits.
Another question that populated was, could it be beneficial to do testing, but instead of taking the benefit away, we offer services/treatment?
So is that drug testing, I assume? I think that having drug testing available to people can be a useful tool when people want it. I don't think it would be part of a harm reduction practice to require that people submit to your analysis or breath analysis, because I think that sends a message that I don't believe you, and that if you tell me you haven't been using, that I can't trust what you say. I also know that there are people I've worked with who have found it to be a helpful tool in being able to rebuild trust with families and being able to know, am I going to be able to pass this urine screen in order to try and get this job? So I think that there are some ways that it can be used in helpful ways within a harm reduction framework, but that does not include mandatory drug testing.
Okay, and one more question. Would you comment further on how there is a personal and social benefit to substance use and risky behavior? I think, I might have asked that question already.
Yeah.
Yes, okay. That's all the questions at this time. We'll go ahead and take that 5-minute break, and we'll see you in about 5 minutes. Thank you. Hello, everyone. Welcome back to today's webinar. Susie Kowalsky, if you're ready, I'll turn the presentation back over to you.
Great. Thank you, Diane. So before we jump in, I saw a couple questions in the Q&A that I want to address. So Nancy asked, are there any guidelines in terms of substance use risk when patients have minor children? And that is actually a great harm reduction question and a really good example of absolutely. What we're focusing on is really the consequences of substance use, not the use itself. So for example, my sister has 3 minor children and she's someone who uses alcohol. So thinking back to that slide on substance use management, some of the things that she does is she implements different guidelines around her substance use in order to reduce the risk of her alcohol use because she has minor children. So she's not going to drink and drive. She's going to have limits on how much alcohol she consumes. There are going to be specific times of day that she might engage in alcohol use. She may talk with her children about alcohol use. She might keep her alcohol stored in ways that when her children were really young, they wouldn't accidentally access. So I think those are some of the components of harm reduction that we're actually really targeting, is thinking about how can we reduce the risk and consequences of this behavior without having to necessarily reduce the behavior altogether if that's not what someone chooses. So I just wanted to comment on that quickly because I think it's a great illustration. So in talking about this idea of feedback effects, we know that the way that we treat people and the policies that affect them impact their personal opinion of themselves, the public view of them, and the policies we create in the future. And so we see this cycle that kind of continues, and sometimes what this leads to is kind of this question, I think it's begs the question, what is our policy toward people who use drugs, and how does that shape our opinions about them? So feel free to put that in the Q&A, but more so just something to really think about is how do we view our clients? How do we think they view themselves? And how do we want them to feel in our programs? How do we want them to think about and view themselves? And what kind of policies would we need to implement in order to support that? I think what happens sometimes is the way that people get viewed is that they're not able to make good decisions for themselves, and from a very deficit-focused perspective, which I think recreates that sense in people of the sense of shame, worthlessness, and inability to take action in their lives. So I think that brings us to the idea of language. So there are different ways that we can talk about people who are engaged in substance use that, sorry, I'm not sure what's happening, that can either be stigmatizing or more respectful. So if you all can go ahead and enter into the Q&A some respectful alternative ideas for, rather than referring to someone as an addict, a junkie, an alcoholic, a craphead, a pothead, what are some more respectful ways that we could speak to and about the people in our programs? Yeah, person with substance use disorder, someone who's engaged in substance use, absolutely. So we want to use person-first language and really center that this person is a human being first and foremost, and they're engaged in this behavior. What about for substance abuse? Yeah, substance use disorder. One of the things that we'll talk about in just a minute is the way that the DSM, and moving from version 4 to 5, took out substance abuse as a definition, and they now speak about a substance use disorder. this is one that I see come up a lot in talking about urinalysis and different drug testing. So we talk about someone as dropping clean or dirty, or someone has been clean for X amount of days. Why might this be problematic, and what are some more respectful alternatives here? Yeah, so I'm seeing some great responses come in. Person who relapsed, person working on recovery, that it's very shame-based to talk about dropping clean and dirty. Absolutely. I think referring to someone as being dirty is extremely stigmatizing. And if I know that there are sometimes people who take pride in using the word that they've been clean. So I also want to clarify, I would never correct a client if they refer to themselves as clean for X amount of days. And I think that us thinking about the way that we speak to and about the people that we serve is important. So I use the term positive or negative urinalysis or drug screen. Again, something that's very neutral, that takes shame and judgment out of it. Yeah, so we treat test results as any other blood work results, right? If someone were going for an HIV test, we would never in a million years, if that person tested positive, we would never think of saying their blood was dirty. It's a really dehumanizing, stigmatizing way to talk about a person. Someone who's in denial, I think, is one that we see a lot. Here I like to talk about someone being in pre-contemplation. I don't think that most people are in denial about the fact that they're engaging in drug use. I think, again, thinking about motivational interviewing, it's not that this person isn't motivated at all. It's more of like, what are they motivated for? And what is their relationship with their drug use? Rather than talking about the idea of someone having an addiction to drugs and harm reduction, we talk about the notion of a relationship with drugs. And the term enabling, I think we can reframe that as really supporting someone. These are things that I think can feel nitpicky or small, but I think make a really big difference thinking to those feedback effects about the way that we think about the people who are in our program and the policies we create and the way that people experience their interactions with us. So this is something that I think is helpful to implement across programs and to really reinforce at all different points of contact. So for example, I talk about this type of language with people on their very first day of work. As part of their onboarding, I explain to them that we don't use these terms on the left in this program because they're stigmatizing and create a dynamic with the people in our programs that isn't very conducive to people's recovery in whatever way that looks. And to talk about ways that we can come up with new language and why this matters. So in thinking about like historical approaches to substance use treatment, we started out with the moral model. So this is really something that frames substance use disorders as really a human weakness, that it's a deficit in someone's character, and that's the reason that they have a substance use disorder. Then we moved along to the disease model, which kind of framed substance use disorder as a chronic health condition in which the patient or the person using drugs would only get well by following the advice of a doctor or an expert, which could be a counselor or someone more advanced in recovery. And the protocol became stop drinking or drugging, attend 12-step meetings, and if necessary, go to a rehab program. And the disease model was definitely an abstinence-only and totally model, and was based on the belief that addiction is addiction is addiction, and that all addiction is a progressive disease which is ultimately fatal if not interrupted. And so the third wave of substance use treatment that we now embrace and which harm reduction falls within is recognizing substance use as being based in biopsychosocial factors that recognizes that substance use results from and creates a complex dynamic that includes medical and biological factors, as well as social and environmental and psychological ones. So now we address all three of these components and include all three of these components in the treatment that we apply with people. So harm reduction is a biopsychosocial model, and we'll talk in a minute about drug set and setting and how those relate here. So we recognize, though, that there's a spectrum of substance use, that it's not a disease that either exists or doesn't, that treatment is not a one-size-fits-all model, that everyone is different, their relationship with drugs is different, and our treatment also needs to be more tailored. So in thinking about what we can do to reduce harm, Diane, I'm not sure if you moved that forward, but we're not quite there yet.
Okay, I'm sorry.
That's okay, thank you. So Carl Hart is an important researcher to be familiar with if you're not, but he's done a lot of research about, he's a neuroscientist and drug researcher, and one of the things he notices is that there are a large percentage of people who try drugs but are not addicted, which shows us that it's something other than the pharmacology of the drugs that causes addiction. So if the vast majority of people are using drugs without problems, which is absolutely what he sees in his research, is that about 80 to 90% of people who use any illegal drug are not addicts. They don't have a drug problem. Most people are responsible members of society. They're employed. They pay taxes. They take care of their families. And as he says, in some cases, they even become president of the United States. So what we see, though, is that it's a small proportion of people who use drugs that do have problems. So it tells you that it can't be only the drug or mainly the drug, which brings us to kind of that biopsychosocial approach. Harm reduction frames substance use as people having a relationship with drugs rather than an addiction. I really like this framework because it's very neutral. It's not pathologizing. Everyone has a relationship with drugs. So regardless of whether you ever use any drug or not, you have a relationship with drugs. And that's something that's worth really looking at and considering and figuring out. We know that all relationships change over time, and that context matters. In certain situations, this relationship can be helpful. At other times, it can be harmful. Another important component in thinking about relationships is looking at power and control dynamics and thinking about where is power and control within this relationship. We also know that people can have a different relationship or goal to different drugs. So there can be people who are saying, I'm really trying to stop smoking cigarettes, but I am totally fine with my caffeine use. And so this idea that you can only have one type of relationship to all drugs is really not true. There's a lot more nuance involved. We also want to incorporate here people's self-assessment of their relationship with drugs and convey a sense of curiosity. One of the other questions that I saw come in during the break was about this idea of preventative measures, which is absolutely a part of harm reduction. And I think that talking about what a healthy relationship is with drugs is a part of prevention. In general, I think that most of us don't get a lot of input or education or guidance about what is a healthy relationship with yourself, with other people, with substances, with other risky behaviors. So I think this is where harm reduction gives us some good guidelines and influence in that way. So Jeff Weil kind of talks about what is a good relationship with drugs. So knowing that the substance is a drug and what it does to your body is an important part of this. So the notion of like, well, this isn't, I think we hear this a lot with marijuana. Marijuana is not a drug, it's a plant. Well, it's still a substance that has an influence on your body. So being able to recognize that when you put that in your body, it does have some kind of influence is an important component. That the person experiences a useful effect over time is another component of a good relationship with drugs. That more or less the benefits outweigh the harms. That you're able to take it or leave it, that your life doesn't revolve around the substance is another part of a good relationship with drugs, and that it's not causing negative effects on your health or behavior. So here, I think this gives us some good guidelines, and I think about, for example, my own relationship with caffeine and whether this falls within a good relationship with drugs. So I know that it's a drug and what it does to my body. It has a useful effect over time. Doesn't really cause me any adverse effects on health or behavior. I don't know, though, if I would be able to say that I could take it or leave it. If someone was like, you just can't have coffee ever again anymore, that would be really, really difficult and upsetting for me. So I think even thinking about a healthy relationship with drugs existing on a spectrum is an important framework, right? That I don't meet all of these 4 of these criteria in terms of my caffeine use, but it doesn't necessarily mean that it's causing me problems. And so I think a lot of people would fall into that area in terms of their drug use. Some of the other phenomena we see around drug use is this idea of maturing out. So the majority of people make changes to their drug use without ever really seeking any kind of treatment. So we know that by age 29, not a whole lot of people are trying a new drug that they've never tried before. And most people stop using things that they had been using previously. We also know that employment is a significant influence on whether or not people use drugs. So people who are employed are less likely to use drugs because they're busy going to work and they have maybe more structure and purpose in their lives. And at the same time, I think it's important to note that the majority of people who use drugs are also employed. So we can see where sometimes life opportunities or values or additional responsibilities like having children or a job, we can think about maybe a singer may adjust their substance use to maintain their vocal range. So there's other life factors that often influence people's use of drugs. So I want to introduce this idea of drug set and setting, which is where we'll kind of spend the rest of our time today. So this was originally developed by Norman Zimberg, who noticed that there are people who use heroin without experiencing dependence, and he became curious about why is that. So it's these 3 overlapping factors that really line up well with the biopsychosocial phenomenon. So there's the drug, which is just what it is and how it's taken. Set, I think sometimes as the mindset or the person, but this is factors related to the individual. And then setting is where and when the drug is used and what kind of stress and support the person has. So Patt and Jeannie Little took Zimberg's idea of drug set and setting and created what they call a MAP, this Multidisciplinary Assessment Profile, that they kind of layered on top of his idea of drug set and setting. And so these are the components of their MAP. These are the different things that they really recommend that we assess in the different people that we're working with to have a really well-developed assessment of someone's relationship with drugs. So we'll kind of go through these a little bit more slowly. So when we're talking about the drug, we're talking about what kind of drugs is the person using, how are they getting it into their body, because that makes a difference, right? If you're inhaling heroin versus injecting it. That's going to have an impact on your experience of drug use. What's the purity and dose, which is going to be a lot harder for people to know around illegal substances. So that's something we want to think about is like what information do people have access to? What is their level of abuse or dependence, which we'll talk about on the next several slides. And included in someone's, in our assessment of the drug component is also prescription medication. So this is both illegal and illegal drugs, prescription or otherwise. So in thinking about the level of abuse or dependence, I think it's helpful to look through the criteria for substance use disorder in DSM-5. And I'm guessing that most of you are already familiar with this, but we're really looking at is the person using more than they intended for a longer amount of time, longer period? Are they having trouble controlling or cutting down on their use? Is a lot of their time kind of revolving around drug use? Do they experience cravings? Is their use causing problems at work, school, or home? Is it causing problems in their relationships? Are they cutting back on social, occupational, or fun activities because of their use? Do they use in ways that are dangerous? Is their use causing physical or mental health problems? And then have they, these last two are the ones that are really physical. Have they experienced, developed a tolerance where they need more of it, or experienced withdrawal? So I think one of the things that's important to notice about the DSM-5 diagnoses is that substance use disorder exists on a spectrum even within the DSM. So we have mild, moderate, and severe substance use disorder. And severe substance use disorder is very similar to what most people think of as addiction. But I like how the DSM gives us this spectrum. I also think it's important to note how relatively easy it is for someone to meet mild criteria. It's also important to note that the DSM-5 does not directly address how much someone is using. So how much and how often someone's using is not part of how we diagnose a substance use disorder. It's really looking more at the consequences of use and the person's relationship to their drug use. So we see here that this mirrors a biopsychosocial approach. We also know that that physical dependence alone is not a substance use disorder. So we can think about that in terms of like prescription drug use, for example. Someone who is diabetic may be physically dependent on insulin, but if they're not meeting those other criteria, we would not say that they have a substance use disorder. I like this graphic that talks about the continuum of use. And again, this is part of our assessment of someone's drug. So this is looking at the level of abuse or dependence. And again, this points out the ways that addiction isn't clear-cut. So someone can be at no use at all, they don't use the substance whatsoever, maybe they experiment, they may have been curious, have tried it a couple times. Occasional use starts to have somewhat of a pattern to it, or maybe you only smoke cigarettes when you're drinking, or you might use sometimes with friends after school or on the weekends. Regular use is where we typically see people start to carry their own supply of the substance, and they might use daily. They don't necessarily have to use daily to be considered regular in use, but it's a part of someone's lifestyle at that point. And we see in terms of regular use that it's not getting in the way of work, school, family, or relationships. So this person's using, but not in problematic ways. And that's really the difference between heavy or problematic or harmful use is now it's causing some problems in this person's life. And then the last part of this continuum of use is someone who's using in a chaotic or dependent way, and that they continue to use substances even though it's causing often quite a bit of problems for them. So what I want to point out about the continuum of use is that people can be in a different place on this continuum with regard to different substances. So someone might not really use alcohol at all. They may use marijuana regularly, and they might use heroin in a dependent or chaotic way. We also know that benefits and harm from drug use can occur anywhere on the spectrum. So someone who doesn't really use alcohol at all but goes out on their 21st birthday and has 21 shots but doesn't really drink the rest of the year, it's not safe to say that they don't experience any harm of their use. We know that people's risk for overdose is going to be higher if they are someone who doesn't really use at all or uses experimentally or occasionally. So I think we just want to keep in mind from a harm reduction perspective that, like I said, benefits and harm can occur anywhere on the spectrum, and we want to be talking with people about what that looks like for them. Moving on to SET, like I said, I think this can be thought of as like mindset. So we want to think about what is this person's motivation for using and their expectation of use. I worked with someone for quite a while who used alcohol very heavily, and for her, she wanted to eliminate times when she used alcohol to manage her mood because she was feeling upset, but felt like when she's out with friends or having a glass of wine at dinner with her family, that was okay. So for her, it wasn't so much about the drug. It wasn't what it was or even the amount. It was more so, what is my motivation and expectation for use? So that is also where we're going to take into account what this person's goals are, because that's going to have an influence on their relationship to this drug. We're going to think about their stage of change, which we'll talk about in a minute. We also want to think about this person's self-efficacy. Is this someone who has skills and experiences that lead them to feel like they're able to make changes in their lives, or is that something that we might want to target and help build up? Has this person ever sought out treatment, and what has their experience been? I'm guessing that most of the time when you begin working with someone, you ask them about their previous experiences in treatment, because that informs not only our work, but we also know that that's going to influence and shape someone's experiences with us. People's psychiatric and medical diagnoses also go in here. So, for example, someone with a liver condition, their use of alcohol might be different at the same amount and frequency as someone who doesn't have a liver condition. And then developmental grid is really the person's background, experiences, and development in the world and the way that that influences someone. So, for example, if someone has a significant trauma history, that's going to have a different impact on their relationship with drugs than someone who doesn't. So if you can all put into the chat some ideas of like, why do people use drugs? What are some of the things that people do? Why are they using drugs? Yeah, the coping mechanism, self-medication, to forget past traumas because they're bored, social influence, curiosity to escape stress and trauma, to survive because of financial challenges. So absolutely, you all are doing an excellent job of naming the varied and many reasons that people engage in drug use. And I think that one of the things we do in harm reduction is acknowledge that most of these are pretty normal human drives, right? It's an oversimplification, but one way to think about drug use is that it's a way to enhance pleasure or to create distance from pain. Those are really normal things that a lot of people understandably want in their lives. So I think it's also important that we recognize that, like, there are real reasons that people would do this. At the same time, we recognize that there's problems and harms of drug use. Again, not taking a stance on the legality, but one of the difficulties of someone using illegal drugs is that we don't have a lot of information about what's in it. Mixing drugs can cause significant issues with polysubstance use. We think about the way that drug use overlays in terms of people's medical situations, including pregnancy, what that looks like in terms of their psychiatric problems. So a lot of times we see people, for example, may start to use marijuana to manage their anxiety and stress, but then it causes more anxiety and stress. And we see a lot of different social, behavioral, and developmental problems, certainly legal problems, and then thinking back to that medical component, we see dependency and withdrawal. So it's also important that we acknowledge within harm reduction some of the harms of drug use. So I'm guessing that this idea of the stages of change is familiar to people. So I'm not going to talk about it too much other than to say that I think even though we are familiar with the stages of change, we often don't really look beyond someone's readiness to stop using altogether. We think about what stage is this person at for the goal that I'm prescribing to them, and do we change our approach to match someone's stage of change? So are we going to work differently with someone who's in pre-contemplation or contemplation than we would someone who's in preparation or action? Or do we sometimes expect people to change their readiness for change to match our interventions? And then as you can see here, in harm reduction, we think of recovery beginning at contemplation. When someone is starting to think about their relationship with drugs, that could be considered any positive change. It is something that we really want to capitalize on and work with someone around. Also, when relapse occurs, we want to blame the plan, not the person. This idea that, and I think that really highlights the importance of preparation, is having a solid plan so that if it doesn't work out, we can go back to the table and figure out, okay, what do we need to do differently about this plan in order to help you get where you want to go? In thinking about working with people in pre-contemplation, I think a lot of times we leave these folks out of our services, which I think we really miss a lot of opportunity there. So we recognize that people who are in pre-contemplation might not be ready or willing to make changes to their substance use, but they might be willing to make some changes in other areas of their lives that will keep them and others safer. So we kind of tend to ignore this population, but if we want to reduce risk, overdose, and death, we have to pay close attention to the pre-contemplators and figure out how to engage with them. So we want to be giving people information and resources, primarily focusing around safety and recognizing that by engaging people who are in pre-contemplation, we increase the likelihood that they might eventually engage in services. And thinking about, this kind of speaks to that idea of developmental grid, of like, what are some of the risk factors and protective factors that might influence someone's relationship with drugs? So we're going to watch a video, Diane, if you want to get that set up, where Dr. Nadine Berg-Harris talks about the ACEs study that you may or may not be familiar with, but she gives a really nice overview of what the ACEs are and the implications that might hold for someone. So Diane, we want to start the video at 4 minutes and then stop it at 7 minutes and 45 seconds, please.
I am in the process. I'm working on that. Thank you.
Okay, thank you so much. Okay, it looks like we're having some technical difficulties getting the video up. So feel free to watch the whole TED Talk. If you just Google ACEs TED Talk and the words you see on the screen there, you'll find it. And it's actually worth watching the whole thing. It's about 15 minutes long, but she does a really great job of spelling it out. So I will do a less great job of giving a summary of what she's talking about here. So the ACEs study stands for Adverse Childhood Experiences, and this was done back in the 90s through the CDC. And this was a really landmark study around the influences of childhood events and long-term health and behavioral health outcomes. So they took over 17,000 adults and had them answer 10 questions about childhood experiences that pertain to physical, sexual, and emotional abuse and neglect, household disruptions like having a family member with a mental illness, a family member incarcerated, parental separation, divorce, and there were 10 of them. And then they correlated that to people's health outcomes as adults, but also things like their level of depression, their substance use. And what they found was a really remarkable correlation between the two that showed that having additional ACEs, as we call them, adverse childhood experiences, has very significant long-term effects on adult behavior. So one of the things that she talks about is the ways that the experience of trauma and childhood adversity is not only just correlated, but it's actually the experience and the ways that our body and brains respond that also contributes to people being more likely to engage in those risky behaviors. So again, just something for us to be really familiar with and mindful of as we work with this population. So I'm going to move along to the last part of the map, which is the setting. So here we're looking at the actual setting during substance use. So who's there, where are you, what are the circumstances, and then also the broader kind of setting around the substance use. So this would include things like the legality of the substance is going to be a part of setting. Attitudes toward that drug use are part of setting. I've worked with people who use heroin on a daily basis who said the amount of shame and stigma that I experience as a daily heroin user is so much different from someone who smokes cigarettes on a daily basis or uses marijuana on a daily basis. And I think that's one of the things we need to be mindful of here with setting. Setting also speaks to the person's support system and ongoing stressors. So someone's relationship with drugs is going to be different if they have really no other social supports and they're very isolated. They have ongoing financial or health concerns. That's going to be different than someone who has a lot of resources and supports available to them. And then our concerns fall in here as well, which I think is, again, a nice part of the map, is that we're a part of the picture too. So our concerns about, I'm really worried this person's going to overdose, or I'm really worried about their kids, or whatever our concerns are that we bring to the table, they do have a part, and they're just a part. They don't override everything else, but they are an important consideration and piece of the puzzle. So this slide here kind of shows how you would use the map. So as we have the drug set and setting, and you would list out the different factors underneath each of those that you know about a person. I think this gives us also a good guideline for questions to ask. Sometimes we focus a lot on drug, so we want to know how much someone's using, how they're using, how often they're using, and that's also where we target our intervention, is to tell people stop using, use less, and we sometimes ignore set or setting. We don't actually know what kind of support do you have in your life, what other stressors are going on. We don't think about aspects of set like what is your expectation of using? What are you hoping to get out of it, and what's your actual experience? What is it that you want around your drug use? So I think that the map gives us a lot of options for potential intervention. It gives us questions to ask, but also if someone isn't ready, willing, or able to stop using altogether, we can ask, where are they interested in making a change? So might they be willing to eat a meal before they heavily use alcohol? Are they going to use in familiar settings with familiar people? Because we know that that also reduces risk. So it gives us a lot of other options of places that we can intervene, which I think helps manage our own sense of anxiety and helplessness when we feel like there's just nothing we can do to get this person to use less. There are a lot of things that we can do to help reduce the safety concerns. And we can see on the map that at the center is this person's experience of substance use. And I want to point out that that is both in the actual moment of use, when someone is using on an individual, like in an individual instance, but also their broader kind of relationship to drug use. Then on the side, you would list the person's goals and the helper concerns. And where I tend to use this, I use this a lot in teams, is kind of mapping out a person. And then a good place to start is often figuring out where is there some overlap between the person's goals and our concerns, and how can we start to address some of those things together. So one example is like using this with someone who's an active heroin user and talking about his drug use, and specifically how to minimize the harm of injecting and using heroin from an unknown supplier. So this could involve coming up with a plan where this person said that he snorted his drug of choice to avoid the dangers of injecting the drug. He bought the drug from an old friend and a consistent person. He had a history of overdosing at least once a year during the time that he was in our programs. And he continued to wear his hospital bracelet so that he could be easily identified if he were to overdose. So we could talk with him about other ways to minimize his risk, like using with other people. And I think this is a good place to think about, like, where has this person experienced harm in his life, and are those harms associated with drug set or setting? And then what kind of questions would you want to ask this person about their use, and what concerns do you have? So in thinking about integrating harm reduction, feel free to put this in the chat, but I want to leave some time for questions. But I would encourage you to really reflect on where are some ways that you're already practicing harm reduction. I think we saw in the beginning that it's not this foreign, novel approach, that we actually use harm reduction a lot already. But for some reason, when it comes to substance use, we think about it a little bit differently. So where are we already practicing harm reduction? how can you apply principles of harm reduction to other risky behaviors? So today we've really talked about substance use, but this could apply with other risk behaviors and absolutely does apply as well. And then where can you further incorporate harm reduction into your practices, and what kind of support, resources, or information would you need in order to do so? So I want to end by talking about harm reduction for the harm reductionist. So I think that it's important for us to really be practicing self-care. And thinking about that beyond the bubble bath, right? That sometimes self-care doesn't feel good. It's things like I hate opening my mail and dealing with like bills and all the letters and things that come, but like I have to, and that's part of my self-care is I have to take care of those things as part of like adult living. So I think sometimes we think of self-care as like an indulgent thing that feels really good, but sometimes it's more just taking care of the day-to-day things that we have to do. And then also thinking about that through a harm reduction lens of this idea of progress, not perfection. The other thing I like to mention about self-care is that sometimes it isn't sufficient and we need treatment ourselves. So if I haven't gotten a good night of sleep and I haven't eaten and I'm feeling hungry and cranky, some self-care might address that. If I bring a lot of personal history and experience around substance use and I'm working in a substance use treatment program and I'm having a really hard time separating out some of my own personal beliefs from my professional obligations, self-care may not address that. That might be something that we really need to seek out professional support and counseling around as well. As a harm reductionist, we want to celebrate small victories because we work very often with a challenging population, and if we're doing the work well, it can be a slow and tedious process, and we're going to be engaged with people who are doing risky behaviors. So we want to be able to celebrate when we see some progress as well. We want to recognize for us that one size doesn't fit all and feel like we have a set of options for approaching our work. One of the things that I really like in thinking about harm reduction and our own ability to sustain ourselves in the work is this idea of vicarious resilience. We talk about vicarious trauma and that we get exposed to all sorts of traumatic material. I know that I also have the opportunity to witness resilience in ways that I could never imagine on a near daily basis. And when I think about and really celebrate and honor the ways that the people we serve are incredibly resilient, I think that helps me maintain myself in the work. So I think a lot of this is really coming down to maintaining a growth mindset, that my job isn't to be a perfect harm reductionist because I don't really know exactly what that looks like, but more having that curiosity and willingness to come back to it and thinking about how I can keep moving in that direction, knowing that the work I do matters. And I think along those lines, I just want to wrap up by saying thank you again to all of you. I know that you all have very challenging positions, and I appreciate your willingness to take some time this morning to think about how you can incorporate more components of harm reduction into your work. So thank you. And we have a couple minutes for any outstanding questions that may have come in. Diane, do you know of any questions?
So I was just going to ask everyone if you can post your questions at this time, if you have any additional questions for Susie. Susie, do you have any good recommendations for where to find resources like handouts, worksheets?
It depends a little bit on what kind of handouts and worksheets you're looking for. the Chicago Recovery Alliance has really good concrete information on safer use strategies. So it really details very specifically things like the angle and speed of injection, how to ensure as much as possible that your supplies are sterile and things like that. So for people looking for safer injection strategies, I would say that that's one resource. I think that that's one of the challenges I often hear of harm reduction is people really wanting concrete tools. And a lot of it is going to be really individualized. Patt, Zenning, and Jeannie Little, they're in the references. Their book, Over the Influence, is written in very accessible, layman's terms. So I like some of that as well.
Can you repeat the name of the previous mentioned video?
Sure. It'll be in the slides, but her name is Dr. Nadine Burke-Harris, and it's an ACEs TED Talk.
Okay, thank you, Susie, and for your time and your expertise today. We're going to go ahead and conclude this presentation by going over some last-minute business details. So, when I conclude today's webinar, your browser will take you to an evaluation on FADA's new website. If you want to receive CE credits or a statement of credit for this event, please complete the evaluation. You will be prompted to register or sign in to complete the evaluation. You can register as a visitor at no cost. For CEs to be reported to CE broker for Florida licensed healthcare practitioners, you must provide an accurate Florida Department of Health license prefix and number the first time you register. After you register or sign in, you will be directed onward to the evaluation. You may consider using the same email address when you register for webinars through our WebEx link and when you set up your profile in FADA's system. This helps connect your attendance and your profile. You will get a second opportunity to complete the evaluation through a follow-up email later today. In about 30 minutes, the sender will be messenger@WebEx. Evaluation will close at midnight on Wednesday, February 13th. We do not email statements of credit. Instead, after we verify attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile. Thank you for participating in today's webinar. We'd also like to recognize and thank especially the Florida Department of Children and Families Office of Substance Abuse and Mental Health for funding today's education. Have a great rest of your day, and please hold for the evaluation.